Hello.
Yep. Hello.
Yeah. Hello. How are you today, Dr.
Thank you. Thank you very much. Thanks for having me.
Yeah. So after a few minutes, we will begin our webinar. So first, let me have a look. Continue the few minute video, and then. Hello everyone, welcome to COXO Free Public Webinar again. This is Jolie. This time I think everyone, most of our dentists follow our COXO Facebook. You will know recently COXO have an activity for post your photo and with the COXO product, and then talking something about you feeling story of with our COXO. Then you can join our activity. So now let me introduce for you how to join this activity. You can see here, first you need to share this activity. Deadline is August 15, so just 4 days more. If you want to join with us, let me share the screen for you. Have a look first. Okay, we can see here. Okay, see this is our COXO Facebook, COXO tab. Then you can see our activity. This time activity is talking about something you use our COXO product and share the experience of our COXO product you feel and take the photo with you and the COXO product. Let me show you have a look how to do that. First, you need to here First, you need to add into our COXO global group, and then you can post a photo with you in the Facebook. Then remember, need to add the COXO product, COXO activity set. Then you can join with our activity. This time we supply very expensive and very good product. You can see our new product, Smart Eye Pilot. This is very new product, or is automatic. No need to consider about the endophilo, the speed and the torque. They will automatic, very safe model. And this is a Ultra Smart, and this is the new LED Q9. So this is a free product, it's a very good product. I hope everyone can take the chance to join with us. Then you can see some other dentists, they join with us, like this sample. They post the photo with COXO product, and then they share to our COXO group. Like this, share to our COXO group, then they can join with our activity. Then you can have the chance to get this lucky draw. How everyone can be tried to get our lucky draw. I see many people is the lucky person. Okay, so and then second, COXO have another activity is for this endo meeting in India. This is an online endo meeting. So if our dentists have time, welcome to join this exhibition online. This is from India IFEA exhibition, and then you can see COXO. Our booth is like this booth. This is our booth online. So welcome to join with our COXO exhibition for special for the endodontic exhibition. So, okay, this is a two activity recently COXO we make it. And then now we need to begin before we begin our course, let me to repeat again about this webinar, how to get the certificate. So remember that before, if during the course, you need to follow our COXO page, then you need to comment. Remember, you need to comment during the course. After the course, comment is not useful. You cannot have the chance to get the lucky draw. So remember, as during the course, you need to comment in this link. And then at last, if you want to get our certificate, please tell me. I will give the link in the comment. You need to fill this link within 5 days. Then we will supply the certificate for this course for you. Okay, so this is our certificate. So if any dentist join our course, you need the certificate, please contact with us. After the course, fill the link for us. And then now let me introduce our professor for this course. This time we are warmly welcome Professor Mohammad Hossein Nekoofar from Iran. This is a very famous professor. I think we can meet him for many endodontic meeting, because he is the director of the National Relations, and then the Tehran University of the Medical Society, and visiting professor of the Antibas University, Turkey. So many. Another is for the immediate past president of the Iran Association of the Endodontic. So many, all is very famous and special for the endodontic. So I hope this time our dentist friend can enjoy our course. So now let me warmly welcome our professor. Hello, Doctor.
Hello there, how are you?
Fine, you?
Thank you very much for having me.
And know this, now you are in Jordan, not in Iran. So what?
Yes. Actually, I'm in the middle of a conference in Jordan, and my followers in Facebook can see the images of this conference. This conference is about the e-medicine and virtual connection, and I'm happy now. I'm in the middle of everything, and then in the middle of a conference, I can use this virtual activity and connect to my colleagues from China.
Yeah, thank you so much for during your busy time, still take time to make this special course for us. Thank you so much. Okay, so now it's time for our doctor to introduce your course for our dentist friend. Please share your screen for me.
Yep.
Our course for this test is on the endodontic of the endodontic relationship and the update. So I think this is a new topic for before our course still not make it. This is a good way for study. So thank you so much. It's time for our Dr. Nekoofar.
Okay.
Okay, give your time.
May I start now?
Yeah.
Okay then. Hello everybody, and thank you very much for joining this webinar, and thanks COXO for preparation of this infrastructure, because it helps us to communicate with each other and discuss some sort of the scientific subjects with each other. As I mentioned already, I'm now in a conference which is related to the consortium of more than 25 universities to each other, working on the project of new curriculum for medicine and medical sciences in general, and using the e-learning and stuff like that. And now this is an application of this virtual communication, which I really love it. And I think this is the future of the scientific collaboration, scientific connections. My topic is the effect of orthodontic tooth movement on dental pulp and periodontal tissue. The reason that I choose this topic, because I think we don't have enough evidence and we don't have enough information about the effect of orthodontic tooth movement, which is increasingly these days. We can see a lot of patients that they have these orthodontic treatments that end up with some unwanted and unintentional subsequent on dental pulp and periodontal tissues, which we need to know that very well. So today, actually, I'm going to discuss about this topic, which is more scientific based rather than just a clinical based. So we discuss a lot of the basic science and a lot of information about the physiology and pathophysiology of the effect of orthodontic tooth movement on dental pulp tissues, periodontal tissues, including cementum, periodontal ligament, alveolar bone, gingiva, and also we speak about the effect of orthodontic tooth movement of internal root resorption of vital teeth, external root resorption of vital teeth, and of necrotic teeth. And also the effect of tooth movement, which ends up to external root resorption of previously root-treated teeth. So if we want to say that, why we should discuss that and why we should keep an eye on this very important topic is because we don't have enough high quality studies. So we don't have any conclusive scientific evidence for the relation between force level and dental pulp tissue reactions in human. We may have some idea based on the case series, based on the theory, and based on the cellular based studies. However, it is not enough for us. So we need to go further and further and discuss more with each other and share our cases with each other to be able to increase our knowledge about this topic. So if we look at the quality of evidence about this topic, unfortunately, we don't have a very good critical appraisal or very good even experimental studies, because this is very, very difficult to get the ethical approval if we want to do some sort of experimental studies on human. And most of the studies that we already have are animal studies and some just individual case reports or maximum case series or studies. Even we don't have enough cohort studies in this topic. But looking at the literature, which I did that for a very long time to prepare this type of presentation for my colleague, I couldn't end up with a lot of good publications. So you can see when we are looking at endodontic orthodontic relationships, we don't find a lot of high-level publications. However, thanks to this publication that you can see the list of them, and most of them done by a colleague, Deringer, they report a lot of good things and a lot of theory. So today I use some of those data and add them up by my own experience and give them to you. However, I want to emphasize that there isn't any rule or there isn't enough evidence to give you a guideline for that. So we want to discuss with each other, and I love to see the questions between and after my talk, because I need your feedback and I need your comments for that. So in general, force application to a tooth during orthodontic treatment may evoke biological response of the dental pulp. This is the duty of the dental pulp to response. And this is, first of all, is a biological response, not more than that. But unfortunately, sometimes it may end up to clinical response of the dental pulp, which we're now going further, and I will list them to you. If first we look at the biological response of dental pulp, the first things that happen is depression of the tissue respiration. So tissue respiration will decrease. And then, very, very importantly, we can see the activity of alkaline phosphatase will reduce and end up sometimes with inflammation, which release neuropeptides, different types or various panel of neuropeptides, and then carry on by producing of inflammatory cytokines, including interleukin-1, interleukin-3, tumor necrosis factor alpha, which you know better than me, they have some effect on the hard tissue and may end up by removal of hard tissue and activity of the clastic cells outside and inside the dental structure. So then, according to that, in this cascade, we will see the blood flow increase, and therefore we have progression of inflammation. Unfortunately, then it ends up with aspiration and vacuolization of odontoblasts, which is very, very important for the survival of dental pulp tissue. And if we don't stop and we don't control that, then cell damage may happen, and programmed cell death is the consequence of the cell damage, apoptosis. Then our body and dental pulp will start responding biologically to that to control the spread of inflammation. So therefore, we have a release of angiogenic growth factors when we have the force on the dental pulp tissue during this tooth movement. So we have EGF, epithelial growth factor, we have vascular endothelial growth factor, we have fibroblast growth factor, platelet-derived growth factors, PDGF, and we have TGF-beta. Then it ends up to angiogenesis. Sometimes angiogenesis is the most necessary things for us. Sometimes, in reality, angiogenesis may end up to formation of new capillary structure, wound healing, and sometimes unfortunately may calcific metamorphosis initiated. As an endodontist, as a dentist, we don't like to see calcific metamorphosis inside the root canal, because the treatment of calcific metamorphosis is not enough, even though we have good illumination, good magnification, even though if we use microscope, we use very sophisticated instruments, still calcific metamorphosis is our enemy. So sometimes formation of new capillary structure and progression of inflammation may subsequently create pulp tissue damage and pain and necrosis. So therefore, the periodontin may damage and internal resorption may happen. So if we go a little more details to that, depression of tissue respiration rate is one of the signs of the change of cellular activity inside the tissue. So if this happens and we see the alkaline phosphatase activity reduced, which is shown in the literature, we have inflammation, we have release of neuropeptide in the area that is affected by tooth movement, inflammatory cytokines, blood flow increase, progression of inflammation, and then vacuolization of odontoblasts, which is the most important cells for us, and aspiration of them into the dentinal tubule. Cell damage, end up with apoptosis. Then we have all the angiogenic growth factors when we applied force on the dental pulp, angiogenesis, formation of new capillary structure, wound healing. Unfortunately, you may see calcific metamorphosis like that. So this tooth, for example, is an example of a tooth under the pressure, orthodontic pressure. So if we have such a tooth, can we treat that if it ends up with necrosis or cell damage? The answer is no. So we need to think about that we are going to discuss that. And sometimes periodontin may damage, end up with internal resorption. Okay. Let's go to the clinical response of the dental pulp. Each of these events may have some sort of clinical response as well. So calcific metamorphosis, as we already showed to you. So look at this tooth, upper central. So this tooth is supposed to be one of the very simple tooth for as a candidate for root canal treatment. However, when we have calcific metamorphosis of that, it seems like that the whole root canal system is obliterated by calcium or calcific deposits. And it is almost impossible to negotiate the root canal system if the root canal treatment is necessary. Sometimes we may have pulpologia. And if we have pulpologia, we need to be very careful about that, because we may decide to do root canal treatment, which is not the case, and which we shouldn't actually do such a thing. And we need to have a very good diagnosis and treatment plan to decide what to do. However, when we have pulpologia, we need to know that that can be reversible pulpitis. So we need to evaluate the pulp status very well. And it can be irreversible pulpitis, which is necessary to do root canal treatment for that. Therefore, treatment planning and diagnosis using the diagnostic system is necessary. However, if we decide to do root canal treatment, and if we find it out it is actually irreversible pulpitis and our diagnosis is irreversible pulpitis, we may decide to go inside the root canal system, get rid of all the tissue from the root canal system, and remove them and do a proper root canal treatment, in which the goal is to get rid of the origin of the pain and origin of the inflammation, which is inside the root canal system. However, we need to stop the forces by orthodontic movement, because if the force is still there, it may not heal very well. So we will again need to be very careful about the treatment and keep an eye on the follow-up of the root canal treatment in that case. And as I said, we may have pulp tissue damage and necrosis rather than an inflamed pulp. So therefore, again, for pulp tissue necrosis, we may have discoloration as well. And sometimes we may decide to start the treatment a bit earlier than all the strategy, because if we stop and we think about that, if we end up with this discoloration like that, then we have problem about the future treatment and makes the treatment much more difficult. And if we leave it, we may have periodontal damage and internal resorption, and also necrosis sometimes, and sometimes without pulp necrosis. Sorry to interrupt, guys, please go ahead, because I'm in the middle of a webinar. Thank you very much indeed. Please close the door completely. Thank you. Sorry, guys. Okay. So if we have a periodontal damage and if we have internal resorption, the treatment is a bit different. We need to make sure that we remove the cells from the area of internal resorption, as well as removing the whole source of the problem in the apical side and the whole source of the preapical disease and internal resorption by a good cleaning and shaping. And before everything, we need to do a proper pulp sensibility test. Because if we don't have enough information about the pulp status, we may decide to do root canal treatment before sufficient information about the pulp. And it is very difficult to have sufficient information about the pulp, especially when it is under the orthodontic movement. Obviously, periodontium is very important for us as well. And we need to do percussion tests, probing tests, electric pulp tests, and put all this information together to end up with a proper diagnosis. Because sometimes when we evaluate everything prior to orthodontic treatment, still we are in danger of consequences. And we need to evaluate, especially if the tooth has some sort of previous trauma. We need to evaluate everything. We need to make sure that the previous root canal treatment has the quality, technical quality of the previous root canal treatment is good. Because if the technical quality is not good, we need to do retreatment. And after retreatment, we should keep an eye on the patients during the tooth movement to make sure that nothing wrong will happen. Definitely, we need a preapical radiograph, because without the PA, we cannot go to the deep diagnosis, and we need to have a proper diagnosis by doing sensibility tests, pulp testing, probing, percussion test, good radiographic, good quality radiographs, and also close monitoring of the case during the orthodontic movement. And we need to be very careful. None of these tests can be rely on that just by one test. So we need to put all this information together for a proper diagnosis. Okay. We know that same thing may happen in the periodontal tissue. So same effects and same biological effects may happen in the periodontal ligament. In the early phase, it evokes an acute inflammatory response in the pedicle. Most of the time, the patients under the orthodontic movement may have some complaint about the pain or even acute pain. We need to be very careful and try to distinguish between the acute inflammatory response in the pedicle and acute inflammatory response in the pulp, because these two are completely different. And we need to be very careful about that. So in PDL, we have vasodilation, which is reversible. We have migration of leukocyte. It can be also reversible. And 1 or 2 days later, the acute phase is replaced by a chronic process involving. When I'm saying chronic process, that means the cells may change and patient may use to this process and pain reduce. And we don't need to do any treatment because fibroblasts may come to the area, macrophages may come to the area, and then based on the cellular activity, we have chronic inflammation. That can be the initiation of the healing, and we don't need to do something quickly. Then we have osteoblast and osteoclast activity, and without this osteoclast activity, obviously we don't have any movement. So we need this osteoclast activity on one side, and then the movement of the tooth may happen according to the forces. So we have osteoblast activity to replace the place that osteoclast removed. So this may have some effect, obviously, and this is inevitable effect. But we need to control the forces based on that, which is the job of the orthodontist. So surface resorption is a very natural happening, and it is not possible to detect that most of the time, which ends up by production of reparative cementum on the surface of the tooth. So surface resorption as a consequence of orthodontic movement is not a nightmare. It's induced by mechanical injuries or orthodontic treatment. Sometimes even scaling or deep scaling and root planning may create such things. And we have a shallow resorption of cementum with involvement of a small amount of underlying dentin. This is a self-limiting process. This is very important. This is a self-limiting process. So the proper diagnosis of that is very, very important. It is a transient effect and should not perform any root canal treatment or any other treatment for that, and just keep an eye and do close monitoring. Sometimes it is also very, very difficult to find that in the radiograph. You may have some radiograph and you cannot observe it in the radiograph, and you don't need to be worried about that. So that was the first. So the first clinical effect of orthodontic tooth movement on periodontal tissue is surface resorption. But then it comes to another term, which is transient apical internal resorption. Let's have a look to that. If we go further, we may have inflammatory external resorption or infection-induced resorption or replacement resorption. So we have various kinds of the resorption when the tooth is under the effect of the orthodontic tooth movement. Okay, let's have a look at the transient apical internal resorption, which is associated with a transient apical breakdown, which happens when we have a movement, or it happens when we have just trauma, such as, for example, a concussion. So that can also create a transient apical breakdown. And again, we need to be very careful, because when we have a transient apical breakdown, we may have no response from the electrical pulp tester or no response from the sensibility test, which we need to be very careful about that. Because if we don't have any answer from that, we may say that, okay, we have pulp necrosis. No, it is not pulp necrosis. It is just a transient apical breakdown. But the most important thing is keep an eye on that. Keep an eye on that and make sure that you have a very, very close monitoring of your patient and see what happened next. So this is recognized by a confined preapical radiolucency. You may have a radiolucency, but it is confined, which results within a few months. So that is very, very important to have a good diagnosis. Look at the history of your patient. So, but if a tooth has a history of trauma and then you start the orthodontic treatment, this close monitoring has more important effect on the outcome, because you need to check your patient very, very regularly to make sure that if something is going to happen, you're going to have some intervention. But the good news is revascularization may occur after control the forces and after control the trauma. And in the longer term, you may have internally resorbed apex, which helps to control the area and will close gradually. So that is also a good news. Very similar to surface resorption. If you have transient apical internal resorption, you may have a very good healing. So look at the case, for example. This case has the history of trauma and also has the history of a restoration, a composite restoration, and a deep care is here. After initiation of orthodontic movement, you can see now the apical breakdown, and you need to keep an eye on this. When you keep an eye on that regularly, you may sometimes find it out the tooth is not going to respond to electrical pulp test or other sensibility test, and then you may decide to intervene and do some sort of root canal treatment and get rid of the bacteria from the root canal system. It is another example. The orthodontist referred their case to me and asked me to evaluate these tooth prior the initiation of orthodontic treatment, which is very, very important. What I do in this situation, I do electrical pulp tester, I do all the sensibility tests, periodontal check, percussion check, everything. And sometimes when the tooth like this one has the history of trauma, I recommend the use of cone beam computed tomography. And then we look at every part of the tooth, and then also the slice interval of we reduce the slice interval of our CBCT and increase the resolution to make sure that we are looking at the apical part prior to initiation of the orthodontic treatment very well. And it helps us as a baseline for the follow-up and for the monitoring of the patient as well. If something happened, we can compare that with the previous CBCT that we already have. Okay, so transient apical internal resorption and surface resorption are not nightmare for us if they happen during or after orthodontic movement. But what about inflammatory external root resorption? Let's have a look. This is produced by destruction of cementoblast in the external part of the root. However, when it happens, other part and other structure of the periodontium are alive, although with varying inflammation decrease. So we may have inflammation decrease, but they are alive. The most important impaired region is the apical third, as you can see in these images. And if the cause extinguish and this inflammation disappears, the process will be interrupted. That means if something like that happens in the middle of the orthodontic treatment, we need to stop applying the forces to this type of teeth. Because if we carry on and if we don't remove the cause of this inflammation, the resorption may not stop and end up with a full resorption of the tooth. The mediators, if we extinguish the cause, the mediators will be greatly reduced and the resorption will stop. And we know that we have stem cells inside the periodontal ligament. And these stem cells inside the periodontal ligament may help us for the repair and may help us for the regeneration. They may produce pre-cementoblast and restore the cementoblastic layer, which is a protection against the future resorption. So if we have inflammatory external root resorption, first of all, identify the cause accurately. This cause can be infective. This cause can be previous trauma, or this cause can be extra force that may apply during the orthodontic treatment. In case of external root resorption, including those of orthodontic origin, we need to be very careful, and it is not necessary to perform a root canal treatment immediately. Root canal treatment should be done only to teeth with contamination or pulp necrosis. That means close monitoring, sensibility test, electrical pulp test, to remove the periodontal preapical inflammation induced by microbial products. So inflammatory external root resorption is not necessarily end up with root canal treatment. When we need to do root canal treatment is the time that we have necrosis. Because when we have necrosis, that means we have, if you remember the first slide that I showed, it gives us this information that we now have apoptosis and necrosis, which is not good to be untouched. So as soon as you have necrosis, you know that you may have infection. So therefore, you need to remove the source of the inflammatory external root resorption, which is inside the root canal system. However, if the source and if the reason of this is not inside the root canal system, there is no logic behind it to do root canal treatment. Be very careful. Diagnosis, use of proper instrument for a good diagnosis is the key of the success for the treatment of inflammatory external root resorption. So this is a case, this is a sample. Prior to initiation of orthodontic treatment, orthodontists evaluate everything. And then during the orthodontic treatment, this inflammatory resorption is initiated. I kept an eye on the patient. I look at each one by reducing the force and just by, for a short time, by stopping also the force, the orthodontic force, and evaluating the pulp status by doing the diagnostic test. Then at the end, when the orthodontic treatment, there was no mobility. However, this resorption happened, the teeth were vital. So there was no need to do root canal treatment because it's not possible to do root canal treatment sometimes even. If we want to do root canal treatment, we may think about the biomaterials and other stuff, which is not the topic of today. So there is no evidence that justifies applying root canal treatment to control external resorption process when the pulp shows vitality. This is the take-home message for us to know that the diagnosis and treatment plan is the most important part of our job. Except when we have pulp necrosis or internal resorption at the same time, or when we see initiation of calcific metamorphosis. Let me repeat this for you. There is no evidence that justifies applying root canal treatment to control external resorption process when the pulp shows vitality. So when we intervene and when we start doing the root canal treatment, when we have pulp necrosis or internal resorption or initiation of calcific metamorphosis. So when we have internal resorption, the treatment is not very easy because the cells and damaged cells can survive in the area which is not accessible for us. So this device, which is an ultrasonic endoirrigation, may help. However, we don't have enough evidence to say that without or with use of this ultrasonic endoirrigation, we may end up with a good healing or not, but it's worth to try. Because if we activate it inside the root canal system, especially when we use sodium hypochlorite or EDTA, we may kill those resorptive cells inside the root canal system and stop the internal resorption process. And when we want to obturate such a canal, we need warm gutta-percha technique, any of them, and we can inject gutta-percha inside the canal to make sure that we seal the root canal system against the bacterial leakage and against the leakage of other cells inside the root canal system. So for internal root resorption, that is the case that we should do. What about infection-induced resorption? That is different from inflammatory external root resorption. Because in inflammatory external root resorption, what we have vital cells that they carry on inflammatory process. But when we have infectious reduced resorption, that is most of the time is because of the incomplete root canal treatment. So if we have such a thing, we shouldn't initiate orthodontic movement, because if we want to apply orthodontic movement, we need to make sure that we do a proper root canal treatment for the teeth first and then start the treatment. So sometimes we may have the history of trauma, and then we have infective endodontic pathosis that they superimpose on trauma-induced resorption, and we need to, it is the time to make sure that we remove the source of the infection from the root canal completely. Otherwise, we have a very extensive and very, very quickly and progressively inflammation and resorption at the apical side, and we need to be very careful about application of orthodontic movement of this type of cases. We got this extracted tooth, it has surface resorption, maybe by initiation of the orthodontic treatment. We have replacement resorption here, which is not too bad. Not good, but not too bad. But we have infection-induced resorption, which is not treatable most of the time. And also we have perforation because of the resorption. Okay, resorbing tissue invades the hard tissues of the tooth in a destructive and uncontrolled way. And therefore, the initial diagnosis is very important. Initial treatment is very important. Prevention also is very important. Prevention, that means we need to do proper root canal treatment for necrotic teeth before initiation of orthodontic treatment. Simple elimination of the cause of the lesion is ineffective in arresting the progress, because usually for the root canal treatment, when we have a problem, we may say that, okay, eliminate the cause. But here, when it is a progressive process, it is very, very difficult to eliminate the cause and wait for the good outcome. Total removal or inactivation of the resorptive tissue is essential, which is not possible to do sometimes. And sometimes we may have a pulpal or internal or a periodontal origin, and we need to distinguish between these two as well. Okay, have a look to this case, have a look to this internal resorption here and some of the apical resorption here. So now it's time to use an activator to make sure that we get rid of everything from the root canal system. We may use different types of warm packing technique to make sure that we seal the root canal system properly, because this is also very important, but the prognosis is not very good, and we need also to keep an eye on the outcome. Sometimes we need to have intervention, surgical intervention, to make sure that we get rid of the infection-induced resorption cells. The last one is replacement resorption. The progressive replacement of tooth structure by alveolar bone, and ultimately tooth loss may happen like this. And this is the result of the orthodontic movement of this type of tooth. It may happen when we have history of trauma, history of avulsion, and other. Most of the time when we have trauma and we have orthodontic treatment, after that on this tooth, something like that may happen. The reason is the death of the periodontal ligament cells and total loss of mobility due to disunion of tooth and bone may happen, and a characteristically high percussion sound is the diagnostic for this type of replacement resorption, and most of the time it is symptom-free and ends up with the loss of the tooth structure. Radiographically, there will be total loss of the periodontal ligament, and evidence of the progressive replacement of tooth structure by bone can be seen in radiograph, and the root is gradually lost, and there is no particular treatment for this type of defect. Okay, this is the last slide that I want to show you, and I don't know, is it possible to communicate with you directly or not, but I will show you this case. This is a case that the my referral orthodontist refer that to me and ask me to have a look and decide what to do prior to initiation of orthodontic treatment, which is very wise and very important. So what we need to do, first of all, we need to look at the history and look at the pulp status and periodontal status of this tooth. Sometimes people may suggest extraction. People may tell you that, okay, do regenerative endodontics, do hemisection, do surgery, do wellable. Do we need to do root canal treatment or not? Based on the history, based on the pulp status. So first of all, we did pulp tester, sensibility test, and the tooth was sensible and vital. And when we look at the history, we find it out there is a history of an impacted premolar there, which ends up with the root resorption because of the eruptive action of this impacted premolar, and an oral surgeon removed that very, very carefully. So the tooth is vital. Do we need to do any intervention? Do we need to do root canal treatment, hemisection, surgery, vital pulp therapy, non-vital pulp therapy, or whatever? Because the tooth was vital, I couldn't justify to do any treatment. So I just wait and monitor the case, which ends up with the bone formation in the area because there was no infection, there was no problem, and the only things that I did, I was just looked at that, wait and see. So proper diagnosis. I look at other teeth as well, and 2 of them need root canal treatment, which I did, and the orthodontic treatment is initiated. So this is, again, another take-home message that before initiation of any type of orthodontic movement, we need to carefully examine all the teeth. And when there is no justification for root canal treatment, it is better not to touch any tooth because of nothing. Okay, thank you very much for your attention, and I hope you enjoy from the collection of the cases that I showed you and helps you for a better service to your patient. Thank you very much. Now I'm ready for the questions.
Okay, thank you. Thank you so much for your excellent course. And then I checked that this time so many dentists from all over the world. I see from India, Cambodia, so Egypt, so many different countries. So I think you are so popular. Dentists like your course this time.
Thank you.
Okay, so let me check some questions here one by one. If any question, our dentists need to catch the time to try to send the question here now. And now let me check one by one what is the question here.
Okay, I'm ready.
I think just now I see your courses, you speak is very clearly. So maybe they can understand very easy this time.
Good.
Yeah, so wait, let me check something. Okay, this is first question. Can you see?
Yeah, that's great.
What is the result from the review?
What results from reduced alkaline phosphatase activity clinically? So when we have reduced, thank you very much, Mohammad Noor, for your question. Alkaline phosphatase activity is one of the very important activity for the calcification process. If we have alkaline phosphatase activity, for example, if we have a resorptive effect, we need alkaline phosphatase activity to end up with the calcification of the area. So the repair of the bone and repair of the surface, resorption and repair of any of the hard tissue damage needs alkaline phosphatase activity. So if the movement of the tooth reduce this alkaline phosphatase activity, then that means we may end up with a progressive resorption. So by controlling the amount of the force, we need to control the activity of alkaline phosphatase and activity of the resorption and opposition of the tooth structure and periodontal repair, and also repair of the surface resorption.
Okay.
Okay.
So, yeah, let me try another question. This time, most of the comments say this is a good cross, and then maybe they very little question for this time checking. Wait a minute.
Yeah, I think this topic is one of the topic that we need actually to be very careful about that. And I tried actually by showing the cases to my colleagues, help them to have some idea about the way that they need to do. And the most important thing is, first, we very, very careful about diagnosis. Second, don't do the treatment immediately. Be very careful. If you don't have proper diagnosis, don't jump to the treatment.
Okay, another question is for the pulp tester.
Oh, that's a very good question. What is the most accurate pulp test? First of all, the answer is it is not anymore. We don't call it anymore pulp testing, because this is actually sensibility test. We check the sensibility of the pulp to different stimulation. For example, cold stimulation, hot stimulation, electric pulp test stimulation, all of them are the stimulation. And if we want actually to rely on any of them, we need to do laser Doppler flowmetry, because we need to evaluate the flow of the circulation inside the pulp tissue. By just looking at the outcome of the presence of the nerve inside the canal, we do electrical pulp tester, we do cold pulp testing and warm pulp testing, just to evaluate the innervation, not the circulation. Therefore, none of them are reliable alone, and we need to put them together, put all this information together to end up with an outcome. Thanks. That is a very important and very good question.
Yeah, yes, that's good. Okay, so this time only these two questions. I think that's your course. Everyone can be easy to understand. You are very professional for explain many cases very carefully to clearly for the doctor. So now most of the dentists.
Thank you very much indeed. Thank you.
Yeah. Okay, so now it's another part is for lottery time. I need you to help me
that's great.
choose the lucky person. Yeah. So let me try to share my screen, and then we choose the lucky person. Wait a minute.
All right.
Yes.
Should I go to that page or?
Let me make it is okay. And then I will let you to begin 1, 2, 3, then we will begin. Let me see this time how many dentists can join with us. Okay, this time is 35 dentists can join with us. Before we begin this lucky draw, let me introduce of our free gift this time. This time we special to supply our handpiece. I think in Iran, COXO handpiece is very popular. Every year, very big quantity.
Yes, it is.
Yes, I know in your university, the same use our COXO handpiece.
Yes, it is. It is very popular.
Yeah, this is a new model. Now it's still not in Iran market. Future will be begin to try to test in the Iran market. And this is the new model for with very big top, Titan model. You can see here have a 4 hole, the air come out. And then this inside the import bearing, Japan bearing. So it can keep very high quality. And this angle, you can see special design for the angle. Then this is very special for the top and cutting force. You can see compare with other brands, so many brands in China brand or other foreigner brand, but our Titan model, the top is much bigger than other brand. This is for, we test many times to make out the result for this. So this handpiece is super tall, super cutting for this model. And even so big cutting force the same, the noise is the very good noise compared with other brand. So this is for this time, the lucky draw for the gift.
Yeah, the winner will be very lucky.
Yeah. Okay. Let me see who will be the lucky person this time. Okay. So we can, Doctor, please help me to say 1, 2, 3. Then let me begin.
Okay. 1, 2, 3.
Okay. We see who is it.
Wow.
Well, congratulations for this Yan Chen Tai. For later, our COXO worker will be contact with you for this. Thank you so much for support us this time. Okay, so now this time the course is finished. Thank you so much for Dr.
You're welcome.
Yeah, for Dr. Nekoofar. You know
Yes,
what?
that's
I just
correct.
know.
That's correct.
Yeah.
That's me.
I just remember Dr. Mohammad Hossein Nekoofar. Last
Very
time
nice.
I go to Iran already so many years ago. I think about 4 years ago.
All right.
Yeah,
Yeah, because of this corona, it is very difficult now to travel, but you are more than welcome to come again.
Yeah, sure. I will go to Iran again. I just remember Salam.
Oh, very nice.
Yeah. Okay, so I hope I can meet you in Iran next time. Maybe
Very
I
soon.
think about 2 years later, I think. For this
Okay.
situation. Okay,
Great.
thank you so much.
Thank you very much, everybody. And if there is any more question, I'm happy actually to answer them. And have a very nice evening. Goodbye, everybody.
Goodbye. Okay, thank you, Dr. Mohammad Hossein Nekoofar. And then now, before we finish this course, let me to introduce our next course professor. Our next course is from Mexico. Dr. Marco. So please pay attention. The next course we use the language is not English. We use is a Spanish language. So welcome our dentists who know the Spanish, such as Argentina, Mexico. So many countries they use the Spanish and Spain. So welcome to join our course next week. Thank you everyone to join our course this time. So now the course is finished. Goodbye everyone. See you next week. Goodbye.